Good evening, sir. Thank you for giving me opportunity to present a review in year 2023 and 24 in nephrology. So, uh, in this review, I will be uh, talking about some articles of 2023 and the innovations in nephrology. So, there's one article about effect of hemodiafiltration medicine. So this kidney failure, it's severe and common chronic non communicable disease which is has increased its incidence worldwide. So this study has included almost uh, 1,360 patients in the multinational RCT. The primary outcome was death from any cause. So they have compared hemodiafiltration and hemodialysis in critically ill patients, and they have found the hemodiafiltration group has a lower risk of death from any cause, that is almost 17% compared to the hemodialysis group. This another meta-analysis about early versus adult patients with acute kidney injury. This randomized control trial has included almost 15 RCTs, which includes 5,600 patients. And this trial has shown this early renal replacement therapy has no survival benefits, and delayed renal replacement therapy has no higher risk of renal replacement therapy dependency or hospital stay. So it shows there's no current evidence to support early renal replacement therapy for acute kidney injury patients without any urgent indications. There's another study which has conducted in Indian populations by Dr. Tukaram Jamale. It's about randomized, again it is RCT regarding earlier start versus usual start of dialysis in community acquired acute kidney injury. So this in this RCT there was almost 585 patients, and they have uh, taken in hospital mortality into consideration and the dialysis dependence at 3 months. This study also has shown this no support for the earlier initiation of dialysis therapy. Then another major article for this year was this waste fluid randomized control trial regarding the donor kidney transplantation use of the waste fluids, that is balanced crystalline solution versus saline. So this RCT has included both adult and children who has received deceased donor kidney transplant, and they have found this delayed graft function was taken as a primary outcome, which was defined as receiving dialysis within 7 days post transplant.
So in the panel, may I request Dr. Gandhi sir, Dr. B.V. Gandhi to join, and he's the mentor in the of Reliance Foundation Hospital Department of Nephrology, and he has been pioneer in India about the ABO incompatible transplant, which was started basically after he came back from US, and he was one of the leaders basically to show us that how we can expand the donor pool by doing ABO incompatible transplant. And followed by, I will ask Dr. Arun Doshi sir to be overboard. And he is one of the consultant and senior member of Department of Nephrology here in Reliance Foundation Hospital. And may I request Dr. Bhavesh Bora to also come and join us. So to first, my question to Dr. Arun Doshi sir. Dr. Arun Doshi, are you around? Dr. Arun Doshi? If Dr. Arun Doshi is not there, so Dr. Bhavesh Bora has already joined.
Dr. Bora has joined. Dr.
Yeah, yeah. Okay,
Doshi,
I'll
I
start
think,
with
is
him.
trying to.
I'll start with him.
Yes, please.
Uh, Dr. Bhavesh, welcome.
Thank you. Thank you, Dr. Das. Thank you, Arindam ji.
Yeah. So we are in the middle actually. We are focusing on initially with dialysis part, and that is always a struggle that in the ICU setup, that whether early dialysis is always better or to keep the internal value, or we have to wait for the normal start, like we are having the indicators for dialysis like hyperkalemia, metabolic acidosis, and others, fluid overload. So there is a trial which was described by Sital meta-analysis in 2023, that early start versus late start. So what is your opinion regarding that, Dr. Bora?
So, as the words they themselves are describing, early start means probably earlier than what you need when you need, and late means later than what you need. So, the actual answer probably is somewhere in between. What I would like to do in my clinical practice is that whatever at the stage when I am assessing a patient, I would like to see what were the previous 2 hours, 12 hours situation, and what could be predictably the next 12 hours situation. And based on that, probably we can time our dialysis more effectively. If you judge that the rate of the pace of illness is too fast and the patient is likely to worsen, then then I would want to err on the side of starting dialysis earlier and not allow irreversible end organ damage with hyperlactate levels going up and refractory acidosis, hemodynamic instability, and hyperkalemia related events. So I would like to prevent those things. So in general, at a given point, I would like to see, say, minus 12 hours, minus 24 hours, and next 12 or 24 hours, and then take a call. I mean, there would be patient where out of fear, in the studies that you have described, that out of fear when they have started dialysis early, and those are protocol based. So clinical judgment wise, probably there would not be any strong reason to start dialysis, but just because the protocol is in place, they would have started dialysis early, and that's how they are not able to document a desired positive outcome in that subgroup of patients. This is my take on it.
Thank you, sir. I think clinically we have to judge, and whatever summarize you have done, summary wise, that we have to rely upon clinical acumen more than the other reports or any other investigational parameters. However, I have another question to you regarding, like, nowadays there is a plethora of urinary biomarkers are coming, especially in AKI.
Correct.
So, if let us say that the patient in ICU setup is having a biomarker which is positive, that indicates that there is a acute kidney injury or which has happened. So, in that scenario, is it wise to start early, or you have to wait, or you have to take the clinical decision?
So, Dr. Das, the whole research related to the biomarkers was oriented to detect the kidney disease early. And if that is the case, by and large, those are early stage renal failure. And probably at that stage, you are not requiring to discuss so much of dialysis requirement at that stage. But the more usage of biomarkers would be in relation to trying to identify the strategies where we can minimize the impact on the kidneys by altering the hemodynamics more effectively, by preventing procedures that can be harmful to the kidneys, and but try and judge that whether whenever there is a renal failure, the patients become more sick, more mortality is related to the hyperkalemia and lactic acidosis and refractory acidosis rather than the number of creatinine per se. So looking at those things, probably we should be using the biomarkers more often to worsen the ongoing kidney damage, rather than deciding on the basis of biomarkers as to when to start dialysis.
Correct. Very good. Thank you, sir.
Thank
Dr. Arundosi has joined or not? I don't
Hello.
see him.
Gandhi sir is joining in a while.
Sir, yet too, Dr.
Hello,
Gandhi
sir.
is joining. Sheetal is back.
Okay, Sital can continue now. Then we can have the panel discussion later.
By that time, I will get Dr. Doshi and Dr. Gandhi to join.
Okay.
Sudeshna, can you just make this next slide?
The previous one. This one is okay.
The next one. I have finished about this balance salt solution and
Okay. The next one.
next. Another article about chronic kidney disease with multi-pronged approach to the chronic kidney disease associated with type 2 diabetes. Can you do the next slide, please? So diabetes affects 1 in 10 of US population, that is almost 33 million individuals, and uh, up out of that 20 to 30 patients with type 2 with multi-prong approach with the type 2 diabetes mellitus, cell modifications and pharmacological approach. Next slide, please. With the diabetic kidney disease with multi-prong approach, we can use interdisciplinary education, then harmonized clinical.
Right now, what has been suggested in this, that we know that there is an increased burden of diabetic population, and India probably is a hub for this type diabetic population, and around 20 to 30% of the population of diabetes will have at a certain period of time diabetic nephropathy needing further uh, need of care. What is has been recently in our portfolio earlier, we have certain medications which basically is targeted uh, towards the decreasing the or the delaying the progression of the kidney disease. Like ACE inhibitors, ARBs, those are, and the blood sugar control and blood pressure control. Those are the mainstay of treatment at that point of time. But the recently in next in this 5 years period of time, we have seen newer molecules which are coming into picture, and which are through different uh, studies showed a tremendous amount of uh, tremendous amount of benefit in those group of patients who towards the delaying the progression in the diabetic nephropathy patients. So one of them is SGLT2 inhibitors. The other one is the finerenone, and large trials has been done with SGLT2 inhibitors like canagliflozin, empagliflozin, and dapagliflozin, and they have been helpful in reducing the progression of the kidney disease, as well as the finerenone, when it has been added to that, it in almost you can say the progression has minimized. So this is one of the portfolio which we wanted to share with the audience, that we are actually in the phase that more number of drugs are coming, and that could probably delay in the progression. And when we know that when the patient goes into the end stage renal disease or CKD stage 5, then obviously we don't have much to offer except renal transplant or the renal replacement therapy in the form of hemodialysis or peritoneal dialysis. So it is a preventive strategy which has been advocated. However, there is a inertia which is there with the patients and the population and the family members uh, about the pill burden. Obviously, that is the one. The second one is the cost of therapy. Obviously, whenever you are increasing the drug one after the another, the cost of therapy also increases. However, in long run, if you see that the dialysis versus the prevention part, prevention is always better than cure. So that is what the emphasis is on at this moment. And for the critical care team, what I need to emphasize is we have to be careful about using the SGLT2 inhibitors and the finerenone in especially in ICU setup, since there are chances that the patient can land up in um, uh, ketoacidosis with euglycemia. The patient might not be having normal glucose level. However, with euglycemia also the patient can get ketoacidosis, which has to be identified earlier for better outcome. The second one is that finerenone. Although it is a good drug, it reduces the fibrosis, and however, there is always a chance that the patient can have hyperkalemia. So we start the drug usually at the initial stage when the potassium level is less than 5. But we have to closely monitor it and also see that during the critical care stay, these medications to be withheld for certain period of time can be restarted when the patient is stable. So many of these SGLT2 inhibitors and the GLP-1A agonist, those are basically can cause potentially decrease in the weight. So we have to be careful. Those who are overweight, obviously they will be happy. However, those who are having normal weight, they have to be careful about this medication. It is really that cause weight reduction. Next, please. Okay, so now going into the from hemodialysis to the certain innovation which has happened in next 5 years or so, and the innovation has been already described in 2022-23. So these are some of the innovations in dialysis as well as in the transplantation. Next. Sital, you want to take over? Sital?
Hello.
Sital, you want to take over from here?
Hello. Yes, sir.
Okay, please go ahead.
I'm audible, sir.
Yes. Just don't go anywhere.
So,
You are audible now. Sit over there.
the new advances in 2023, what we have got is this normal, we have found after peak to human kidney xenotransplant, we have found this normal graft function uh, in the patients. And why the transplantation is needed? Because this lot of mismatch between demand and supply in view of renal donors and recipients. So every year, there's almost 40% of the listed patients die within 5 years while waiting for the transplants. So in this xenotransplant, actually, they have like it deleted some peak xenoantigens, and they have done insertion of protective human transgenes to induce the immunologic tolerance. And what they have found with this study is this this normal graft function even on the post-operative day 7 in the patients. Next slide, please. So other newer innovations in the nephrology on horizons are there are a lot of inventions happening around in nephrology, like portable artificial kidney, and then wearable artificial kidney, and the most fascinating is implantable bioartificial kidney. Next slide, please. So wearable artificial kidney, so it has uh, this is a wearable device which can be wore around the body, which is about weight around 5 kg, and it can do continuous dialysis up to 24 hours. It uses the central venous catheter, and the patient can be mobile with the dialysis device. They have this portable this artificial kidney. They have used this disposable sorbent cartridge, which is capable to work as a normal physiological kidney. Next slide, please. The artificial kidney, it has been developed by a team of led by Shuo Roy by University of California and San Francisco. This artificial kidney, it's uh, different from the all other renal replacement therapies in view of it takes function of tubular cells also. The proximal tubular epithelial cells are seeded in biocompatible membrane extraluminically, and it is kind of all in one culture vessel containing the cells mimicking the renal epithelium. It's kind of organ on a chip, uh, which is based on the cell cultures platform. So this is technically it is approved by FDA. It's in the preclinical trial. Next slide, please. So artificial intelligence in nephrology. The artificial intelligence has been used in various aspects in the nephrology, with diagnosis, imaging, and the prediction of the diseases, and the prediction of severity of the diseases, and diagnosis. The next slide, please. There's another device for the hyperkalemia measurement. It is just like a glucometer. It is developed by cardio renal team, called as Tenor device. It has got approval by US FDA for it is at home blood potassium measuring device. This device can measure the potassium levels within 5 minutes in the and it can be useful in chronic kidney disease patients who has this possibility of hyperkalemia in such patients. Next slide, please. There are some newer anti-hyperkalemic drugs like patiromer and sodium zirconium cyclosilicate. They are cation exchanges, the potassium binders. This is oral potassium binding polymer, patiromer, which can be used for the hyperkalemia. But it acts with the exchange of calcium in the GI tract for the potassium, and extra potassium is excreted in the in the gut, and that's how it helps for the hyperkalemia in CKD patients. Next slide, please. Zirconium cyclosilicate. It has also has come in the market.
Thank you, Sital. Hello.
Yes, sir, you are
Audible,
audible. Please carry on.
Yeah. So whether Dr. Gandhi sir has joined or Dr.
I texted you. I think some technical snag, it's quite a bit of possibility. So I would ask you and Bora sir conclude because we are also running of time. And
Okay.
as previously declared, we will have a separate year in review for our critical care nephrology. I just had a word with Dr. Deshpande. We will also have a separate year in review for critical care nephrology. So I think you
Excellent.
conclude, uh, and then we will repeat this session because of so much of trouble in the connectivity, and also other other panelists couldn't join. We will repeat this one. So if you can please conclude.
Okay. So thank you so much. As panelist, Dr. Bhabesh Bora sir, thank you so much for joining. And this is basically newer advances which has been in horizon, and whatever has been uh, offered to us at this moment of time. And just we wanted to know, uh, before in conclusion, tell that there are a lot of activities probably will be happening in next 10 years time, and probably in next few years we'll see that the xenotransplant is coming up in a big way, although I don't know whether it will be prevalent in India or not, but in Western countries they probably will be much more uh, active in that. And the other thing which is fascinating will be wearable artificial kidney. And with that, I think I should conclude. Thank you for Sital for
Sir,
the
anything on the
presentation.
AI part that you were always there because you took that anything on the predictiveness on the AKI part that we can anticipate in 2024,
Yeah,
particularly now that we are also planning to initiate the AKI pathway, whether uh, we will have a sort of preemptive diagnosis of AKI itself, and we can rather than diagnose, we can prevent AKI to happen at all.
uh, it is basically the biomarkers what has been described by Dr. Bhabesh Bora, that we are having in our portfolio certain urinary biomarkers which are measurable now, and it is not a bench to bedside, it is not a lab criteria now, it is bench to bedside. You can actually do the test in certain and those are available nowadays. However, the interviewing part is basically there are lots of biomarkers which are present, especially so in the proximal converter tubule. If it gets injured, there is a specific group of biomarkers which will be released. If there is a loop of Henle injury, then there is a specific group of biomarkers will be released. If there is a collecting duct, likewise. So now things, wow, the AI is basically will help us in the sense that one is, if the biomarkers can be identified early, then we can say that this is a potential candidate where any type of uh, nephrotoxic injury or nephrotoxins should be restricted, and that will basically lead to prevention. It is like preventing the acute kidney injury. The other thing is that whether we can predict the recovery process, in the sense that biomarker, if it is declining day by day, you can say that instead of urine output nowadays, which is a marker, and the creatinine value, which are marker, we should know that these are not the good marker in acute kidney injury. So if the biomarker will say that, it is going day by day, it is going down, so that is a sign of recovery. But we don't know still what is the threshold of that biomarker, the level where we can decide whether this injury has happened, or it is a pre-renal kind of thing, or it is recovering or not. So that threshold has to be identified first. And in certain areas, artificial intelligence also has been utilized, is basically identifying the acute rejection in transplant scenario. So lots of biomarkers are still coming up in the urine. It is like, you can say, urine as a
Biopsy.
urine as a biopsy marker. Instead of doing kidney biopsy, you can see in the urine that this is these are all biomarkers are present. So this is probably going towards cellular rejection kind of thing. So that has been already started floating around. So probably in next few years, we'll be seeing more utilization of artificial intelligence in our practice scenario also. Arindam, you are not audible.
Anything in the dialyzing technique, maybe on the filters, or in the pumps, or in the anticoagulation, which we can anticipate in 24?
Dr. Bhavesh, you want to take this question?
So, in terms of filters, I think we have a great deal of filters available, which would kind of enhance the dose of dialysis that is delivered. And in terms of anticoagulation, there are more and more machines which are compatible with regional anticoagulation, so to say, as to those patients who are at a high bleeding risk, where we are trying to do the dialysis without any anticoagulation in the form of heparin or anything. We can have regional anticoagulation in those patients, can manage them more effectively. So that is one new area. And depending on the kind of dialysis that is offered, if you are able to remove middle molecules more effectively, then whatever uremic damage that is occurring in form of, say, neuropathy, or in terms of dialysis dementia and things like that, can be slowed down. So more number of patients, we can add more number of years without significant uremic complications in them. Yeah.
Just to add to Dr. Bhavesh Bora's talk, now probably we are heading towards pore bank. Okay, what is pore bank? Dialyzers are basically capillaries, hollow capillary with small pores inside. And through that pore, the diffusion happens or convection happens. And now we have capability by nanotechnology of insulating the pores of the size what we want to remove. Let us say that the patient is having cytokine storm. We have those specific order or manufactured dialyzers by which we can take out cytokines, which are basically that same size will be filtered out. The others will not be filtered out. Likewise, middle molecules, likewise, the other phosphate or any other removal of any other uremic toxins. One is that. Second is the hemodiafiltration. World is now approaching towards hemodiafiltration. That's why the one of the research papers, we have highlighted that there is a significant benefit of hemodiafiltration versus dialysis in critical care scenario. However, the problem is basically the hemodiafiltration. There is more of the newer dialysis machines will be needed. We require ultra pure water from the RO. Ultra pure water is basically you have to measure the endotoxin level to be minimum. That has to be taken care of. And we have to have a replacement fluid which has to be more than 25 liters in a day. What we are achieving at this moment is with CRRT, with CBVSDF, we are able to achieve that same type of the convective solute clearance. Whereas CRRT is a continuous phenomenon. However, hemodiafiltration is short duration dialysis by which we can utilize the same convective function. And initially it was initiated, the thing was initiated by a group called as in the Italy, the Ronco group, Claudio Ronco, and it was propagated later on to the other parts, but the problem is the cost. That is what the problem is. In Indian scenario, it is very difficult to get all those replacement fluids and then ultra pure water, all those things will require cost. Thank you, Arindam.